where are my helpers at? So welcome everyone. It's good to see you. We're going to infuse just a little bit of energy in this crew coming out of the break. My helpers down here have some Launch Tower Health t-shirts. Launch Tower Health is a kind of an incubator accelerator that works alongside with Novant and RevTech Labs to help this entrepreneurial ecosystem grow. So we've got some t-shirts, but they've got to hear you screaming and clapping in order to get the t-shirts. So give it up for my helpers here trying to get t-shirts. All right, let's go. Now, more. Yeah, we got two more. Yep. Nope. I'll throw it. Where are we at? All right. There we go. Awesome. All right. Thank you, everyone. So very privileged to get to sit up on stage with this exceptional gentleman sitting to my right today. I'm going to let him do a quick introduction, and then I'm going to elaborate on some of the stuff that he's not going to tell you.
All right. Well, thank you very much. My name is Bobby Mukkamala. I'm a ear, nose, and throat physician in Flint, Michigan, which is my hometown. I share an office with my wife, Nita, who's an OBGYN, and it's where our patients affectionately say they go to get their earwax cleaned out and their pap smears. Not the most wonderful advertising, but that's what we're known for in town in Flint. But the other hat that I wear is I serve on the board of the American Medical Association, was chair of that board last year. And at our meetings, whenever it is that I speak up, the AMA sort of senior management, sort of their eyes go back and they're like, oh, he's going to say something about interoperability and tech. And I've become known as the guy that is constantly harping on technology and why it is that it's not doing what we need it to do in healthcare. And so when an assignment like this comes up as an opportunity, I get dispatched. So that's why I'm here today. But great to be here and learned a lot already and very insightful conversation so far.
Bobby, thank you so much for coming. An accomplished ENT surgeon, member of the AMA, and a restaurateur, car collector. And so I'm going to tell one of your stories, if you don't mind, that you shared backstage with me about your restaurants. 6 restaurants in Flint?
6 restaurants if you count the hard cider place and the brewery as restaurants, but yeah.
That you're part of. And the first one that you opened was a tapas restaurant. Now, I'm from the middle of nowhere, Ohio, very rural, very much like Flint, very small town. And when he opened his tapas restaurant, several of his patients were kind of offended that he had opened a topless restaurant.
Flint, Michigan didn't know what tapas was, and so they heard topless, and they'd be like, Dr. Mukkamala, we didn't think you'd be the kind of guy to open a topless restaurant in downtown. And then we had the conversation about tapas and not topless, and now everybody in Flint knows what tapas is.
Awesome. Well, thank you so much for being down here. We're going to continue some of the thread and maybe go a little bit deeper. You mentioned interoperability. It came up earlier today in Dr. Butler's talk, and I think Dr. Butler probably wins the award for being most well color coordinated, and his clothing this morning looked amazing. But talk to us a little bit about some of the archaic hurdles that healthcare has to kind of survive, specifically as it relates to interoperability.
Yep. So this is something that I just thought that this was how it was everywhere. When I start to talk to people about what our daily workflow is. So my wife Nita and I, we share an office together. You go in and you go to the right if you want to see me, you go to the left if you want to see her. We do our thing, and then this gets communicated to our referring physician. So she and I are both specialists, ear, nose, and throat. She's an OBGYN. It boggled my mind that she would go to the hospital. She operates on Wednesdays. She'd go to the hospital on Wednesday, do an amazing high-tech procedure like a robotic-assisted hysterectomy, right? So cutting-edge stuff. And then she'd come back to the office, and she would print out the operative report for what she did and stick it in the fax machine and fax her operative note on her robotic hysterectomy to the primary care physician so that they know that their patient, Mrs. Smith, got a robotic hysterectomy, and this is what happened. And it was just crazy to me, and I started to think about it. And this is literally like Fred Flintstone living in the same time as George Jetson, right? And this is a little bit of a generational metaphor, but But the fact that, here she is doing cutting edge stuff and then using a fax machine is just wrong. And this is a failure of our health innovation, our health tech sector to make that better, right? I mean, she should be able to, that should just be a seamless transition of communication. And the fact that that's what that's like is a problem. And that's what I'm hoping conversations like this solve. And honestly, my hope is that solution will come from Charlotte. I'm very encouraged by the conversation I've already sort of witnessed today, that if we are going to solve that problem, it's either going to come from within technology to solve it, or from DC saying you must solve this or else. And we sort of have that threat as well with the 21st Century Cures Act that basically says that everything needs to be interoperable, and if it's not, there's a fine associated with it. And there's these somewhat perverse incentives perhaps to silo that information. The fact that she does this at one hospital and they want to keep that information, and the less portable it is, we have 3 hospitals in Flint, Michigan. Literally, it takes 7 minutes to get to each one from our home. And one is on Epic, one is on Cerner, and one is on another system. And they don't talk to each other, right? She does the operation in one place. God forbid that person ends up in a car accident the next month and ends up at our level 1 trauma center, which is another hospital. And now they're faxing information over. And after hours, when there isn't staff to sort of man that fax machine, the new hospital is ordering the same CAT scan that she just ordered a month before because they don't have that information. That's Fred Flintstone.
Yeah, it's there's absolutely 100 reasons that solution could come from Charlotte. RevTech Labs has its roots in fintech. We're a banking center of the country for sure, if not globally. If you and I decided to go grab a drink in Brazil, my financial information would follow me the whole way to Brazil, right? My credit information, very sensitive financial information, right? And yet if I fall off the curb here and they take me to Atrium instead of Novant, they don't even know I'm allergic to penicillin, right? Yeah. And yet as consumers, we're like, that's just how it happens in healthcare, and we shrug our shoulders and move on.
And manning the fax machine, if there's somebody to send the fax about your records, and if there's not, then we're guessing or relying on you. When you just had a car accident, hopefully nothing is seriously wrong with you, but you're rattled. And then they expect you to be able to answer a question about, what's your past surgical history? And you're trying to think back, okay, was it an appendectomy? Was it my gallbladder? What am I allergic to? What was the name of that medicine I reacted to 10 years ago? You're in zero position to be able to answer those questions. You shouldn't have to, right? We have so much robust technology to be able to make that conversation unnecessary, and yet it happens in every single emergency department across the country from coast to coast on a daily basis. And we're so much more capable than that.
The tapas restaurant in Brazil doesn't ask me for my credit score, right?
Right,
They get my
they
credit
know you're
card,
good for it.
and we're all good. Yeah, exactly. So 2-physician household in Flint. How do you get physicians more engaged in this innovation process and fixing some of those issues that we're facing?
Yeah, it's so necessary because I think we need to have a voice at that table. So much tech is created for us and not with us. And I witnessed this. There's a HIMSS conference. So you guys probably know what that is, but I attended for the first time. I think it was in Las Vegas. And I was baffled when I walked into this room of 40,000 people creating tech for healthcare, and the paucity of physicians in that room. I mean, I walked around, I was just kind of looking at badges and stuff, and there were some, chief medical officers and things like that, but so few physicians that were sort of also collaborating and sort of looking at products and giving their opinion on it. And that's the problem, that when this technology gets created in a void, it gets created for physicians and not with physicians. And I think that's an important piece that's missing. The more we're involved in that, and it used to be that when we saw people get their medical degree, right? Somebody graduated, I went to the University of Michigan. If somebody graduated in my class and chose not to practice medicine, chose not to do a 5-year residency in otolaryngology or a 4-year residency in obstetrics and gynecology, and instead went to work for industry, a generation ago, that was a failure, right? Like, can't practice medicine, must be going to do something else. Now, when I hear about somebody doing that, I'm like, oh, thank you, God, right? For going out and not practicing medicine and instead sitting at the table where everybody in this room is sitting to create that technology to make our lives better so it's easier and better outcomes to practice medicine is fantastic. That's admirable. And so but that's that's still sort of unique thinking. I think that if you ask the 1 million physicians in this country, a lot of them, maybe even the majority of them, would still look at that decision to not be in the clinical practice of medicine, instead be contributing to the development of technology to improve healthcare. Half of them would still probably see that as oh, you couldn't cut it seeing patients, so you're doing this. That is so wrong in thinking, and it's so needed, but that's the mindset that needs to change.
Yeah, it's interesting. There was a very well-known physician from Johns Hopkins. The name came up, I think the lady from Microsoft mentioned earlier, Hopkins. And I was talking, he's kind of this well-respected, very visual character in healthcare. And I was talking to some of his peers who do more day-to-day care, and they said, oh, he's not a doctor, he's a suit, right? Yeah. And so there's this divide that even inside the physician ranks that we put amongst ourselves to separate and divide, and it doesn't really do anybody. It was like demeaning him that he was a suit, not.
Yeah, it's just, it's so wrong. And we need to change that from within that culture. And then when I go to a conference like HIMSS or come to a place like this, and then half the seats are filled with people that have learned the science of healthcare, right? They've gotten their degrees, they're the physicians, but choose to apply that science and that experience in the hospital, in the halls, in the emergency departments, in the offices as they're rotating through. They can bring that knowledge to the development of healthcare. And that's when we really accelerate the development of useful technology.
So I know you're here representing the AMA, and they've got a specific penchant and bias towards starting that, some of that, inserting physicians earlier on. Talk to us a little bit about how medical education needs to change, to really get the physicians engaged. And I think it's expressly relevant here in Charlotte, as we're currently the largest city in the United States that doesn't have a medical school, but we have 2 of them that are coming in here in fairly short order. And we talk about kind of a clean slate and being able to rewrite how that medical education starts for physicians to contemplate being involved in innovation, entrepreneurship. Anxious to get your thoughts on some of that.
Yeah, I mean, I think it's an amazing opportunity. When I think back to my medical school, you spend 2 years in a classroom learning this part of the anatomy or that part of histology, or what goes wrong when an organ does this instead of this. And then 2 years in the hospital rotating through everything from psychiatry to neonatology to OBGYN to otolaryngology, and then you go out and repractice, right? Zero exposure to the innovation that we will rely on when we actually get into practice. And so the opportunity here to have medical students in the same environment as the people that are creating that technology, to be able to contribute, to be able to learn what's out there, is a fantastic opportunity, right? I mean, what a cool evolution of medical education to be able to include them, expose them to it so that they kind of know what's out there, how it gets created. What I know about what gets created is just sort of what I see on TV and I read about and I see stories on the news, but I don't know what it's like to innovate. I don't know, and I'm learning a lot just from sitting here about what people go through to get product to market that's useful. But if I knew that when I was a student, I can contribute to that, I can appreciate it more, I can understand, okay, why it is that it turned out like this instead of that, and help it actually be something that's useful. And so I think that opportunity to have students involved in an ecosystem like this that's creating that technology is fantastic.
Yeah. So Dan and Ashley, kind of prescriptive medicine there for future events to make sure that we've got segments broken out specifically for medical students that are going to be part of our ecosystem.
So and just in case, teach them how to use a fax machine.
Right, exactly. Yeah, that's
hopefully they'll never need those skills, but for now they will.
Right, exactly. So along those lines, the information that comes off a fax machine is data, and you've got some pretty interesting anecdotes around how data and kind of maybe even process are designed to be there, you think, to improve the quality of healthcare and to make it more efficient. But there's so many different layers of that whole paradigm that you have to operate in that are really a little more than bureaucracy and kind of get in the way. Can you share some anecdotes on that front?
Yeah, for sure. I mean, so when we think about the stuff that comes in, so for example, let's say that somebody gets a new app and it's now recording their blood pressure, right? And then that's something that needs to get transferred to me. One, I need to have something to receive that data. And if that app says, what fax number would you like this data faxed to? Next thing I know, I'm coming in the office in the morning on a Monday, and I've got 50 pages of blood pressure readings from Mr. Smith that is app generated and gets faxed to my office. What am I to do with that data? So there's an importance in having that data be useful data, right? So in the entire 50 pages that come through on the fax machine, what 5 lines are actually important? Whether it's blood pressure measurement, whether it's somebody's chart. That's something that technology should help me be able to distill from that 10 pages and these thousands of lines what it is that's important, and then even put that into my electronic health record, right? How great would it be if somebody comes in and their allergies, their medications, their past surgical history, whether or not they've had their nose worked on before, what their hearing test was, if these automatically get populated into my health record, which shouldn't be that hard to do. I know that we have the brains probably in this room to accomplish that, but that's not where we are, right? That's literally something that gets faxed over and then gets filed by my office staff on Monday morning to say this is this person's audiology. In fact, when I was sitting here, I was doing some filing, and across my fax machine came this picture. Let me see if I can pull it up. And it's basically a black and white picture of somebody's eardrum that came across my fax machine as important data, right? This is supposed to help me figure out what to do with this patient when I see them in my office next week. This is a black and white picture that came across my fax machine, right? I can't tell if it's red or is it pink. I mean, how is this useful to me? And yet I have thousands of pages like this come every month. So this is where technology can help me by putting it where it needs to be, where it's useful to me, and then distilling out all those things that aren't useful to me.
So if I'm hearing you right, we need to stop calling these smartphones and call them smart fax machines instead? Is that right?
Yes, I mean, there's so much potential there. Just even talking earlier before in the setup room, you know, there's utility in these devices, but it's making it so that it can be incorporated into my practice in a useful way. What I really dread is a solution to a problem that's an icon on my desktop for that particular problem, right? I've got 30-ish problems. What I don't want is 30 icons on my computer or my office staff's computer to say, okay, I need this from this place. Let me click on that icon and I can get it, right? That just needs to end up in my patient's chart without needing these 30 icons. Because then I got to figure out, okay, well, they had HAP last month and I can't find it on HAP. And then I call them up and they say, actually, no, my spouse got transferred and we got Blue Cross now. And so then I got to click on the Blue Cross app. Like that's not ideal, right? Yeah. So these solutions, creating that desktop icon and that app to solve the problem and saying, okay, we're done, we can check that box, that ain't gonna cut it if it's not seamlessly integrated into where I'm looking for that information. I don't want 30 icons, right? I want to be able to or open up Mr. Smith's chart and be able to find it under audiogram or, you know, past medical history or past surgical history and know that it's there.
Yeah, it creates a really insane barrier to try to think about how you get over that, right? As you think about people kind of innovating and disrupting the system. And yeah, I've got a point solution, right? Maybe I've got a great way to solve 90% of your back pain patients that come in, they don't need narcotics if they follow this particular protocol. And the only thing you have to do to use my protocol is you just got to drop the icon on your desktop, right? And you're like,
yep. Right, so that's the back pain patient, but then there's another icon for the sinus CT scan. There's another icon for the allergic reaction. There's another icon for, you know, childbirth. And so there's all these icons and apps to solve individual issues, but and then they're the icon for the, you know, X-ray readings for somebody with this particular insurance, right? The radiology result for that insurance company. But what about this insurance company?
Insurance, oh my gosh. I had a fun little anecdote I have to share. So my wife had elbow surgery a couple years ago. She and I are both pharmacists, and I won't name the hospital that we went to, but we go to the hospital. She goes back in the pre-op. I get pulled in, and they just finished pushing her fentanyl as I walk in. And 4 seconds later, she looks at me and she goes, "Hubin, did I tell you I tried the spicy chicken sandwich at Chick-fil-A yesterday?" "No, honey, you didn't." She goes, "It was so good." "That's great." She goes, "Hubin, did I tell you I tried the spicy chicken sandwich at Chick-fil-A yesterday?" I go, "Just a second ago." She goes, "Oh, I said that out loud?" I'm like, "Yeah, you did." Can't script it any better. Anesthesiologist walks in the room and he goes, "Mrs. Pope, would you like general anesthesia today or a nerve block?" And I go, "You're asking her?" And he goes, "Oh, did they give her the fentanyl already?" Yeah, they did.
Yeah.
He doesn't know who I am other than husband, right? He doesn't know that I'm a hospital pharmacist. He goes, well, which one do you want? And I never pass up a chance to screw with somebody, so I go, which one's cheaper? And he looked at me like I had 6 heads because he didn't know what our insurance company was. Yeah. He had no clue. So here's my wife, a pharmacist, me, a pharmacist, anesthesiologist, and we didn't have access to the information we needed to make a good decision.
Yep.
I told him nerve block because it was the right answer, and he turned around as fast as he could get out of the room, right? But that interoperability conversation, like very educated people didn't have access to the information to make a good decision.
And that's an elective procedure, right? So what happens if this is 9 p.m. in an emergency situation? No way that's going to happen. If it can't even happen for an elective procedure that's scheduled for weeks in advance or months in advance, it's definitely not going to happen for that emergency broken arm in the middle of a high school football game.
So in addition to getting faxes on your phone, what are some of the innovations that you've seen that have really made an impact in the quality of care? Or maybe which ones do you see that are really lacking that need to come in? I'll let you, dealer's choice on that one.
Yeah. I mean, I guess at a bare minimum, I would just love for the basics that I need to know, that every physician needs to know when they're taking care of a patient. What their past medical history is, what their past surgical history is, what their allergies are, and their list of medications, right? So those simple 4 things to travel with the patient and be seamlessly integrated into any healthcare record that is going to be used to capture that episode of care, like that's the low bar, but we don't have that yet, right? And so we've got the ability to do a robotic hysterectomy, but we don't have the ability to seamlessly be able to see if somebody has a penicillin allergy, right? It still requires that question, right? Are you allergic to penicillin? And if they happen to go to this hospital today and that hospital tomorrow, the question get asked twice, right? And maybe that person remembered this day that cephalosporins have a 10% cross-reactivity with penicillin, and when I say Keflex, they will understand that, but then forgets that or forgets to mention that, and all of a sudden it doesn't get captured. That's a problem, right? And that's, heck, if that happened in this next few years, I would say, boy, that is a huge leap forward, right? And I mean, everything else that we can create with technology would be wonderful, but that's what I would say is the lowest hanging fruit, and would love to see that happen.
It's exasperating and empowering at the same time. To think that the bar is really that low, that's the dime that needs to be.
Yeah, and Cerner has it in this record, but this hospital across town that's 7 miles away has Epic, and it's not in that record. And literally, that's a middle of the night fax if somebody's there to man the fax machine. And if not, you're relying on the history that's given by the patient with the broken arm that's in pain that happened to forget that they had a penicillin allergy also.
So does it take federal influence to kind of extract that as being owned by an Epic system and owned by a Cerner system, and to make that kind of a universe? I mean, the Health Information Portability and Accountability Act. I mean, the word portability is in HIPAA. Yeah. Like it's written in, and there's 2 A's in HIPAA, is not 2 P's. A little pet peeve, by the way. But does it take federal influence to make that happen? How else do we do?
I mean, I guess I see the solution as coming from one of 2 ways. Either conversations like this that realize that this is what's needed, let's create the tech to make that happen, and get those 2 organizations to, or the 2 products to sort of transfer that information, or from above by enforcement, saying do this or else. I don't like that solution, but honestly, the more years that go by, we've had our electronic health record in our office for 15 years and still buy fax toner every week, that I'm not holding my breath that that's going to happen quickly, and therefore some force of that to make that happen, I would welcome that at this point. Yeah. Looks like there's a
couple questions. Yeah, Olga. Let's get you a mic first real quick. Yeah, and if other folks want to think of questions, we've got about 6 minutes left, and Bobby's being very generous, wants to give a lot of time to the audience.
Olga Muller with Kepler team. And sorry, I've been listening to some of these conversations. For me, as a technologist, the way it feels is we keep discussing how inconvenient the old bicycle is while we have Porsche in the garage, but we won't take it out. This problem had been solved at least 6 different ways by various technologists. It's there, it's on the market, it's available. We keep talking about why we're sending fax. I can tell you, at least I can name 12 of startups that had solved this problem through blockchain, through interoperability systems, through you name it. And we keep discussing that it's not being adopted. I understand they're kind of new, it's scary. Then there are maybe too many different ways of solving that problem, and we are waiting for one dominant way to emerge and for everybody to adopt it. And yes, it's associated with costs, but maybe we should be talking about adoption rather than how inconvenient the old bicycle is. The Porsche is there. There's different types of vehicles, and they're ready, they're there, they're available for everybody. So maybe it's time we start discussing how we use it instead of how do we invent them. So.
Yeah. So I guess what I would say is absolutely those are available, but how do I know? And somebody mentioned in the last talk that what I invest in as the solution to this interoperability is going to stay there, and is it going to be able to talk to what the same product or a different product that the physician down the street from me that's sending me that patient has invested in, right? So there needs to be or somebody that moves to Michigan. Like we have a lot of, what do we call them, snowbirds, right? So people that live in Michigan in the summertime and live in Florida in the wintertime. What is it that's going to make the Florida system be able to communicate, right? So there needs to be, and whether it's FHIR, whether it's some sort of other sort of language, that needs to be something that is universally agreed upon and enforced and make that portable. Your Verizon phone has zero problem talking to my AT&T phone, zero problem. Right? But if you have a solution that works for this population in this community, and then the Florida community has a different solution, and they don't pre-populate the fields in my EHR, that is not a great solution. And so that's where the gap is between what exists and then incorporating it are those issues. Cost is one of them, but just making sure longevity and true interoperability, not limited to just a local geography, are issues. Jason.
So I agree with both of you, and it seems that when you say it's going to have to be enforced, I agree with that as well too. But it seems like healthcare systems are not going to be able to do that. I mean, they've been trying right here and there. The government's going to have to do that, right? Regulatory policy. So how is that going to look? How would that happen? Is that going to take 10, 20 years?
Yep. So there's the 21st Century Cures Act that has within it language that basically says if this data is not portable, there are fines associated with it. Of course, that's going to be stuck in courts for a while. These vendors that are potentially culpable for those fines are going to fight it. So the language exists within the law. Now it becomes enforcement of the law and getting it through whatever litigation and stuff is pending to basically say, yes, if you aren't going to, if Epic on this side of Flint, Michigan and Cerner on this side of Flint, Michigan at 2 hospitals, if that data needs to be sent by fax and it's not something that automatically populates when the patient gives birth at this hospital because that's where they do OBGYN and then goes to this hospital because this is the level 1 trauma center after they broke their arm, if that's not immediately portable, when they need it, then there's a fine associated with that. When somebody starts having to cut checks for not having that available is when it'll become available real fast.
Other questions from the audience?
Hey, I would love to revisit some of your early comments about engaging physicians in the innovation kind of ideation ecosystem. Barring leaving practice altogether, what do physicians need in order to be willing and able to carve out a little bit of their time to throw to the effort, provide the lens, the feedback? Doesn't have to be an idea so much as a reaction. So no need to come prepared. We are, as Paula mentioned on the panel earlier, really looking for ways to engage physicians more in our innovation work, but it is a big challenge for obvious reasons.
Yeah.
So would love any ideas.
Yeah, I guess I'll just look at myself. And if I looked in the mirror and said, what's stopping me from spending 4 hours a week working with a healthcare tech company in Flint, Michigan to create the solution that they want to do? And really, it's getting backed up in my office, right? Telling my patients that, I need to book you out an extra 3 or 4 days because I'm spending this time. So there is a shortage of workforce that is exacerbated by COVID, and that a lot of people just sort of said, you know what, I was going to retire in 10 years, I'm just going to do it in 5 years. So creating a workforce that has that flexibility, 2 more medical schools opening up here ought to help with that. But being able to incorporate into my workday without falling behind clinically. I don't want to make my patients suffer because I want to lend my brain to the development of technology. So doing that, the time in the day is the issue. But if somebody sort of starts that way and basically says, you know what, this is my interest, right? And early on in my career, before my practice builds to the point where I'm seeing 40 patients a day and have a 3-week backup, getting people on the early end of it that said, I'm going to create my work week around this aspect of my life that I really like to contribute to. So doing it in the early career physicians that don't know how to use a fax machine, but certainly know how to apply technology and AI and those things that we haven't even yet talked about. I think that's the way to accomplish that.
So I think all of the imperative change that has to happen in healthcare in this country starts in one place, and it starts with really amazing people who are very approachable, who are very educated, and actually give a shit. And I think you are all of those things. Thank you so much, Dr. Mukkamala, for being here.
Absolutely. No, enjoy the conversation. Thank you. Thanks, Scott.
Great.
Yeah.
Thank you so much, guys. We will go ahead and reset this.